Hear me, everyone? Give me a nod, Lisa. Can you hear me? Give me a nod, Lisa. And yep, yeah, okay, thank you. Yeah, so welcome everyone to the Magnetic Resonance and Radiotherapy webinar number 2, organised by IPEM's MR Special Interest Group. If we move on to slide number 2, I'll introduce myself. So that's not changing on my screen. Ah, there we go. Yep, so my name is Mark Cowan. I'm going to be coming at this from the radiotherapy physics perspective. I'm a radiotherapy physicist from NGH, and I'm also chair of the Radiotherapy Special Interest Group for IPEM. We've got some housekeeping just before we start the webinar. Could you please make sure your microphones are on mute throughout the webinar to prevent disturbing the speakers? If you have any questions, could you put that into the chat and we'll try and go through that at the end. And also, you've probably just got a notification on your screen that this webinar will be recorded. I've also been asked to direct people's attention to the MR safety exam. That's the American Board of Radiology safety exams that have been hosted by IPEM and are available on IPEM's website. Some more kind of somber kind of housekeeping is that we are in the national period of mourning at present after the passing of Elizabeth II. So I've been asked that could you refrain, actually could we move, yeah, sorry. I've been asked that can you refrain from posting anything regarding this webinar to social media. This is a Cabinet Office request for kind of NHS staff. The other thing is, just before we start, we're going to have a minute's silence. So without further ado, please shout up Michael and Lisa if I've missed anything, but I think we're going to move into the 1 minute silence and beginning the talk. So I'm going to just set my watch now. So I think we'll start a minute silence now, if that's okay. That's a minute. Thank you very much, everyone, for that. Okay, so I'm going to introduce now Michael DeBeck and Lisa McDade from the Christie, who are from the healthcare science team and radiographer team there, who are going to talk about MRI protocols and patient setup for radiotherapy planning.
Okay, yep. So we're going to discuss this topic. So this is the second part of the webinar series, and this essentially follows on from the publication of the IPEM Radiotherapy Guidance Report. And in this talk, we will summarize sections 6, which is patient setup for MR simulation, and section 7, sequences for MRI for radiotherapy planning. Obviously, if you want a more in-depth review, please see the publication. So I'll begin with going through why we might use MR for radiotherapy treatment planning. Then I'll pass over to Lisa, who will talk about patient preparation and setup. And then I'll talk then about MR protocols and acquisition. So as we all know, CT is the standard imaging modality for radiotherapy treatment planning. But we know that this essentially doesn't provide a good soft tissue contrast, and this can lead to target and organ at risk delineation uncertainty. And if we just look at these examples here, we see a head and neck tumor case with a group of clinicians trying to outline the tumor, and we see this intra-observer variation, and we also see it here in this lung cancer case as well. So when we have this uncertainty, we could end up overdosing normal tissue regions or underdosing the tumor, which isn't ideal. We also have this issue with normal tissues as well. So for example, in the heart and in the brachial plexus examples shown here, and this again can lead to overdosing of normal tissues, leading to normal tissue toxicity. We also have the issue with CT of the ionizing radiation exposure, and this is obviously not ideal if we want to do multiple follow-up scans, especially in the pediatric population. The advantages of using MR for radiotherapy planning, however, are the excellent soft tissue contrast, and this can clearly be seen in these examples here, where we have the prostate on a CT and then the prostate on MR, where we can clearly see the central gland, any lesions within the central gland, the peripheral zone, and the rectum, which is obviously an organ at risk in the prostate case. And in the gynecological case, it's a lot more easier to make out the target, the uterus, the cervix, the rectum, and the bladder. We don't have ionizing radiation with MR. We can image in arbitrary planes, for example, transverse, sagittal, coronal, or even oblique, and we can also have quantitative or functional imaging capabilities, which we can incorporate into our planning workflow. However, we still need CT because we need the CT, or the CT Hounsfield unit essentially is related to electron density, which is needed for the radiotherapy dose calculation. Whereas the MRI signal intensity that we get from our images is affected by multiple factors, including tissue proton density, tissue relaxation properties, sequence parameters that we set on our scanner, and field uniformity, to mention a few. So we still need the CT scan. This is until MR only planning for all tumor sites, but we are definitely not at that stage yet. So we still need the CT scan, and we register our MR and our CT data sets together. So we want the MR and CT to be in a similar position as possible, spatially, to reduce any registration uncertainty. So we want to make it, the use of this MR scan. So we can sort of split the purpose of MR into two categories, so disease staging and response assessment. And essentially the patient setup would be the same as we do for a standard radiology protocol, and similarly with the MR sequences. However, if we're looking at radiotherapy treatment planning, the patient setup should match that of the CT planning scan and radiotherapy treatment position as far as possible for our image-based registration. And our MR sequences need to be have high geometric fidelity to match our CT planning scan. So now I'll hand over to Lisa, who will chat about patient preparation and setup.
Thanks, Michael. So when we're considering patient setup, and apologies, when we're considering patient setup and our workflow, we need to think about many factors in order that we provide a safe, efficient service. We talked about safety considerations last week in terms of maintaining MR safety and not risking life-changing or fatal accidents. So consideration to the workflow is vital. And first of all, you need to consider the patient pathway, and it needs to work for your service. A typical pathway would include, we get a patient referred for booking, we then have a simulation, we plan treatment, and the patient attends. So we're going to concentrate on this simulation part of the pathway. So which do we do first? Do we do CT first or MR? And again, it's going to depend on your pathway, your local policies, and perhaps the disease group that you're treating. A reason for doing CT first is, as Michael said, we need CT to calculate electron density. If we have gadolinium-based contrast hanging around in those tissues, it's going to affect the attenuation of the CT, leading to higher Hounsfield units. So we perhaps want to do CT first in those patient groups that are having gadolinium-based contrast. There are some papers coming out now to suggest it's perhaps not an issue, but until that's proven beyond doubt, I think it's probably prudent that we stick with CT first in those groups. CT first allows tattooing on set. Does that lead to a more accurate MR setup? We don't know. In addition, other patient positioning devices such as thermoplastic shells and backbags, they can't be adjusted in the MR environment because the means of adjustment, whether it be your water bath or the vacuum pump, are MR unsafe. So they have to be done in CT first. However, for some disease groups, such as some of the pelvic groups, you might want to do MR first, because what we can do is we can do multiple imaging over time to look at things like bladder filling, so that we can then dictate the more accurate time for the CT planning scan based on it's personalized medicine, isn't it? We're adapting it for that individual patient. In addition, we can do multiple scans if we have unknown things such as a large rectum. We don't have to rebook the patient. We can just give them an enema and rescan them. There's no dose implication. So patient prep. Patient screening, as we talked about last week, is vital in MR for safety. But a lot of the considerations are very similar to CT. So some people, you can adapt your forms for common criteria so that you're not duplicating questions to patients. But if you're going to do that, then you need to consider that pathway and which comes first, CT or MR. So you just need to give some thought to that. The prep for MR needs to mirror that used for CT, but MR can dictate the prep for CT. As I've mentioned, for things like bladder filling or rectal size, we can image a patient over a period of 40 minutes to watch the bladder filling and predict which image is the best to use for planning and therefore treatment. Upper GI prep is a little bit more difficult as the sequences are so much longer than CT, and the stomach emptying can cause a problem. Some sites are using anti-foaming agents to reduce the volume of gas in the stomach and duodenum. That's a bit of a work in progress at the moment, but it's something to think about. Also, just because IV contrast is used in CT, it might not be necessary in MR. So that's where you liaise with the radiology department to see whether you need to give contrast for those for some tumours. Ideally, you want your patients to change into cotton gowns or scrubs for their MR sim. We image the patients with bare skin, and usually what would happen in sim is that patients would just slip their t-shirt off or their clothes off in the scan room. We don't really want to be encouraging that in an MR environment because of safety considerations. And they need to really remove all the jewellery apart from the wedding bands. And here's just a couple of videos showing the importance of good patient preparation. So the video with the yellow contours on the sacrum is intrafraction motion. So same session, multiple imaging points showing intrafraction motion. And the very fast moving video with the blue contours around the uterus are interfraction motion, just to show you how variable it is over time. So what do we need? We need an index flat tabletop or an overlay of some kind that's indexed the same way as it is in the rest of the department. And we need a coil bridge to balance our receive coils on. We don't want the coil bridge deforming the body contour at all. So it needs to be suspended above the patient. And as per last week, we need to make sure that all our immobilisation is absolutely safety labelled. It's really important that we don't get immobilisation mixed up with the rest of the departments. This is one example of setup for head and neck with a coil bridge. And here is a different vendor showing a different setup, different coil bridge. So there are many available, and you just have to work with what you can. We also need a laser bridge. Then they're not essential, but they do help reduce positioning errors and reduce the risk of rotations and translations. But if we don't, what you do have to remember with laser bridges is that you need to turn them off at the mains. You don't just power them down and switch them off in the room. They have to go off at the mains, and this is the reason you get RF artifacts from them if you leave them switched on. Back bags. There are two kinds of valves. You need to make sure that you're using the MR safe valves and that the vac bags are appropriately labelled. This is a Calder valve, so it's an MR safe valve. The unsafe valves, you won't notice that they don't have any particular pull, any torque when the vac bag goes onto the scanner table. But the risk is that the field, as the vac bag is moving through the field, it will loosen the valve. The valve will shift, and air can go into the vac bag, which will obviously affect the integrity of the patient positioning device. So you need to make sure that your vac bags are appropriately labelled, so that the mould room staff, or if it's a non-MR staff group that are making these vac bags, they know which are the ones to use. Carbon fibre is used quite a lot as a immobilisation device as well, whether it be for headrests, for brain or head and neck treatments, or spacers for the head and neck treatments. And we need to really be avoiding them. There was a theoretical risk of heating because it's an electroconductive material, but that's not really been borne out. There's a few studies out there that have shown that perhaps it doesn't heat as much as we thought it would. But what it does do is it causes this RF shading that you can see here. And obviously that's going to be an impact on your treatment planning. Rulers. We use rulers all the time in radiotherapy for patient positioning to make sure that patients are straight. These steel rulers are the most common. They are horrendously MR unsafe. They're very magnetic, most of them. So you can transfer, you can get gold rulers if you like, or most of us stick to plastic. Likewise with monitoring equipment, this is a reason why perhaps some centres that are performing GA would like to do the MR first to make sure that only MR safe / conditional equipment is in use. If you're running from CT into MR with your patients, you need to have a process whereby you have a checklist of checking your monitoring equipment. It's perhaps best done as a checklist, so you literally tick off each piece of kit that's monitoring that patient to make sure that you don't have any unsafe equipment going in the magnet room. Because the problem with GA patients is they won't be able to tell you when it's burning. They won't be able to tell you when it's hurting. So you need a very, very robust pathway for those groups of patients. Patient positioning, we know that patient positioning has to be accurate, it has to be reproducible, and it needs to be comfortable, because the patients need to be positioned in that setup for some period of time. Some of our MR sim protocols are about 45 minutes long, so the patients need to be able to tolerate them. If you can, it's nice to time them so that the CT and MR similar sort of time points, so the internal anatomy is as similar as possible. Appreciate that's not always easy, but if you can, it's helpful. Because this is what happens if we don't get things right. So what these two images are showing you is difference in position of this is an abdominal compression belt. This sort of increased density here is where it's just flattened the fat tissue to make it more compressed and dense. And we've shifted it, we've got it in slightly different position in this image. And you can see that the internal anatomy is very, very different. The gallbladder's gone from being a nice sphere to an ovoid shape. The liver tissue is completely, it's pointing more over here. Our bowel is completely different. Our kidneys, ignore that this isn't contrast, this is a flow artifact, but our kidneys are in different position as well. And this becomes an issue with image registration and contouring. How do we know our contours are accurate if our image registration is so off because our patient positioning isn't uniform? So it really is worth spending that time and getting that part of the pathway right. Additional challenges, bare skin. As I've said, we need to image our patients with bare skin so that we can see tattoos or skin markings or whatever system you use for your abdominal compression, if it's acetate. And that can lead to problems if the skin touches. We talked about it last week with creating loops in the body, can cause skin burns. And this is an example from the literature. That there are a few others, but this is what we really have to avoid. What we do is we tend to get our patients changed into scrubs before they go in the room, because it means that they can quickly reveal the piece of skin that we need to see, but it maintains the rest of their dignity because the rest of them is covered up. In addition, we can get loops with hands. If when we're creating the back bags, we need to be careful how we loop the hands, that we put a barrier between the two, and so that we don't get that skin to skin contact. And also when we're setting up back bags, the elevated arms, they can get in the way of headphones. We have to give ear protection in MR. It's mandatory that we give ear protection in the form of earplugs and headphones. And so you need to be making your back bags with your headphones on. So you need to get a separate pair of ear defenders to do that. Beakleys, if you're simming with a shell and the beakleys have been left on, they cause artifacts. You can get oil-filled beakleys if you want to go over to those, but the metal ones do cause artifacts. The headphones also slip on the thermoplastic shells. So I don't know if you noticed, but we use back bags. We use sandbags to keep the headphones elevated. And emergency evacuation, as we talked about last week, if a patient becomes unwell, they cannot be resuscitated or given intensive care in the magnet room. They have to be taken out. So to summarise, the patient pathway might be different for different disease groups, and you have to sit and work it out for your centre, what disease groups you're treating, and what is the simplest pathway and the most effective use of your imaging modalities for your staff. You do need to consider your immobilisation, particularly if that immobilisation is identical to what's used in the rest of the department. That if it looks similar or the same, make sure that your MR safe or conditional immobilisation is clearly labelled, and staff do that check before they go into the magnet room with the immobilisation. And so staff knowledge, skills and competence with MR safety training is absolutely essential. And as we talked about last week, you need to practice your emergency evacuations, and you need to practice them with the most complex, complicated patient setup that you do, so that in the worst case scenario, you can get that patient out quickly. And I'm going to now hand back to Michael to go through protocols and sequence acquisition.
Thanks, Lisa. So essentially this sort of section came about due to inconsistencies when we looked at a 2018 survey of all radiotherapy departments in the UK on how they used MR in the radiotherapy workflow. So if we just pull out an example here, we found that around 18% of centres were using diagnostic MR sequences for brain planning. However, these might not have been adapted or may not be suitable for radiotherapy treatment planning. And we noticed this sort of inconsistency across different tumour sites for a variety of different factors. So the sort of aim of this part of the report was to sort of standardise protocols to offer sort of the starting point, and for anyone who's already using MR for radiotherapy planning to adapt their protocols as necessary. So it's just one example of a MR sequence protocol that we might use in the brain. So we might have a 3D T1 weighted sequence for registration. We may also use this for target and organ at risk delineation, and we have examples of these sequences at the bottom. A 3D T2 weighted sequence for target and organ at risk delineation. We might use a 3D flare sequence. Essentially, this suppresses the cerebrospinal fluid, which helps us essentially outline the edema and may help sort of differentiate the tumor from the surrounding edema and tissue. And then we might use a 3D T1 with gadolinium contrast to essentially highlight the tumor and areas of defective blood-brain barrier and metastasis. And this example just shows the tumor highlighted with this TU. So this protocol could equally be used for radiology or radiotherapy, but the sort of parameters or how we optimize these sequences will depend on what its purpose is. And also, if we're using it for radiotherapy, we need to think about whether the image will be contoured on directly. So will the oncologist contour the tumor directly on the MR and then register it to CT, or will the MR image be used as a reference, for example, on a PACS workstation next to the treatment planning system? So we've provided a list of different sequences for a range of tumor sites in the report on table 9. So have a look at that if you're interested. But if we're looking at the sort of differences between MR for radiology versus radiotherapy, so the purpose of MR for radiology is for detection, characterization, and staging, whereas for radiotherapy treatment planning, it's more for target and organ at risk contouring. The field of view we can use in radiology, sometimes we might use a reduced field of view, which just covers the prostate, for example, whereas for planning, we need to include the organs at risk, and we probably want to include surrounding bony anatomy as well, such as the femoral heads or even the whole body contour to aid in the registration to CT. Slice thicknesses for radiology, we tend to use sort of thick slices and sometimes with gaps between slices to sort of reduce the acquisition time and increase our signal to noise ratio. Whereas for radiotherapy treatment planning, we want our MR slice thickness to be comparable to that of CT. So for example, 2 millimeters, we don't want any gaps between our slices, and ideally we probably want 3D isotropic sequences as well. Geometric distortion, generally less than 3 mils tolerance for radiology, but for planning, we might set it to 2 mil over the clinical volume of clinical significance. We might use 3D sequences so that we can enable 3D distortion correction and test the distortion or characterize the distortion with a large field of view distortion phantom. Signal uniformity is generally tolerated in radiology across the image, but in radiotherapy, this might be important to have your signal uniform or uniform signal intensity across your image, so for intensity-based image registration. Bandwidth, which I'll talk a bit more about later, is essentially a trade-off between fat water shift and signal to noise ratio in radiology. For radiotherapy, we want high bandwidths to minimize fat water shift and susceptibility effects. The imaging plane for radiology, multiple planes we can use depend on what we're looking at, so coronal, sagittal, obliques. Whereas for radiotherapy, we generally want either acquired or reconstructed transverse images to align with CT, and also some planning systems may only accept transverse images. So to sort of arrive at those different considerations, we need to optimize our MR sequences, and essentially the MR optimization is a trade-off between SNR resolution and time, but we also need to consider patient comfort, distortion, image contrast, and artifacts. So for example, if we have a standard MR sequence, which we use in radiology, if we want to convert that for radiotherapy purposes, we might need to reduce the slice thickness and take out the slice gaps, but obviously that's going to increase the scan time, and this could impact on patient comfort, and if that impacts on patient comfort, that can in turn impact on, for example, artifacts in our image. So we need to consider all these things when we're optimizing sequences for treatment planning. MR offers multiple different imaging contrasts, so T1, T2, flare, stir. We can also give gadolinium contrast agents and use quantitative imaging techniques such as diffusion weighted imaging. But developing the images for treatment planning requires a multidisciplinary team approach. So it should include an oncologist who is ultimately going to be using the images, a radiologist, clinical scientists, and radiographers from both MR and radiotherapy backgrounds. As Lisa mentioned, you want to plan the order of your MR and CT scans, especially if using contrast agent. And the use of gadolinium should be based on local protocol or discussion with your radiology department. Obviously, geometric accuracy is really important for MR treatment planning. So essentially, MRI uses magnetic field gradients to assign spatial information, and we can get distortions in our fields which are either scanner or patient induced. And these can be split into sort of two classes, a non-uniform magnetic field. So the most uniform, or the magnetic field is most uniform at the center of the magnet, but when we introduce a patient, for example, if we have air tissue or metal tissue in this example, metal tissue interfaces as shown in this example with these hip implants, we can get these local magnetic field fluctuations or distortions which cause this signal dropout, signal pileup, distortions around that area as well. We also need to consider the magnetic field gradients, which essentially give us this, assign the spatial information. The gradients are most linear at the center of the magnet, and they sort of tail off as you move towards the edge. And this occurs both in the sort of Z or longitudinal direction and also in the transverse direction as well. So we can minimize these sort of distortions with sequence optimization, and we'll quantify them with quality assurance. So geometric accuracy, we aim to achieve distortion of less than 2 mils within the volume of clinical significance for planning, and maybe less than 1 mil for stereotactic cases. And as I mentioned, these local fluctuations in the magnetic field may cause these things to occur. But we can use one simple way of, or one way you can start by trying to reduce these effects or minimize these effects is by using spin echo based sequences, as these are generally better than gradient echo based sequences for minimizing these effects. The other thing we need to think about is fat water shift. So fat and water protons resonate at slightly different frequencies. So we can see these shifts. In this example on the bottom left, we have kidneys, and you can see we have, because of the fat water shift, we have this sort of signal pile up where the fat and water signals overlap at this edge of the kidney, and we have this sort of dropout on this edge and this edge of the kidney. And if we look at the egg examples as well, we can see we have this fat water shift due to the shift of the sort of whitey fatty part of the egg on the outside, sort of shifting into the watery yolk. And we want to aim for this shift to be less than 1 millimeter. And one way to achieve this is to increase the receive bandwidth. And as you can see, when we've increased the receive bandwidth from 12.5 kilohertz to 50 kilohertz, you see that we've minimized this effect. But we also see a decrease in the signal to noise ratio as well. So you need to be mindful of this. But we've provided bandwidth requirements for different MR systems in the guidance report in table 7. So please see this if you want some more information or guidance for your particular scanner. You should also apply 3D distortion correction where available, or 2D distortion correction at a minimum. On some systems, you can only actually apply 3D distortion correction on 3D images. So in this example, we've scanned a distortion phantom, and if we look at these 3 plots, essentially on the x-axis we have distance from isocenter, on the y-axis we have sort of distortion, and then this is a threshold of 2 millimeters, and then all these little points are voxels essentially within our volume. And if we don't use distortion correction, we can see a lot of these are out of tolerance, and then when we move to 2D distortion correction, we have an increase in the number that are within the 2 mil threshold. And then when we switch to 3D distortion correction, which also sort of corrects in the slice direction as well, we can see the majority of the points are within tolerance. And this example just shows a slice through the phantom where we have distortion correction not applied and then applied underneath, just showing you the sort of impact that this has. And this is available on all scanners. As I mentioned, the optimal field uniformity and gradient linearity exist at the isocenter of the magnet. So for this reason, we obviously want to scan the volume of clinical interest at the center of the scanner, or at isocenter. So in the superior inferior direction, we want to ensure that our table is set to scan the field of view. So for example, the brain in this case, so the center of the field of view at the isocenter of the magnet. This isn't always set by default on your system, so make sure you just set your FOV to scan at isocenter of the magnet. In the anterior posterior direction, we could use supports to get the anatomy at isocenter, also thinking about using the same immobilization techniques across MR and CT. And then left, right, and as with these other directions as well, we need to think about accurate setup using laser positioning. This is just an example where the FOV wasn't set to scan at isocenter, so we see this MR scan and CT overlay, and when we registered them together, we found that the top of the head in the MR scan was deformed, and that was due to the scanner not scanning the patient's head at the isocenter of the magnet. As Lisa mentioned earlier, we need table overlays and coil bridges, but these can increase the distance between the receive coil and the patient. And in turn, this can reduce the signal to noise ratio and signal uniformity across our image. And we can compensate for this by increasing the number of signal averages, but this can increase our scan time, using additional flex coils, for example, using these lateral loop coils in this head and neck case, and also enabling uniformity correction. We can get artifacts related to patient discomfort, respiratory and cardiac and bowel motion. So ways to minimize these are obviously to improve patient comfort. And again, that might mean trying to reduce your scan time. Use immobilization devices, antiperistalsis medication, and bladder filling and emptying protocols. For respiratory motion artifact reduction, we might want to use respiratory triggered or breath hold sequences, but these may not, or the resultant images may not match the sort of respiratory position that you have for your CT. So if you're doing an abdomen, for example, you might have a mid-vent or average respiratory position from your CT, but your respiratory triggered or breath hold might be at end exhale. So you need to consider this. You may only use these images for reference, for example. We can use non-Cartesian based sequences, and these essentially are available on pretty much all scanners now, and these can minimize motion artifacts. So for example, propeller, blade, or stack of star based sequences. We can also use spatial saturation bands over the abdomen, and this can reduce breathing artifacts, especially in the pelvis, abdomen, or thorax cases. Another thing to point out is it's useful to review perpendicular reconstructions of transversely acquired 2D images just to check if you've got any jumps between your slices as well. Just to touch on MR-only planning, so this is available for a limited number of treatment sites, and I've just got two examples here, one from Philips and one from Siemens. If we just look at the one on the left, we have Philips MR CAT, and essentially this is available on the scanner, and essentially it you acquire a Dixon image, and this allows you to reconstruct a water-only image and a fat-only image. And then this is registered within the software to a bony atlas, which assigns Hounsfield units to spongy and cortical bone. So then essentially our pseudo CT or MR CAT data set then comprises 5 Hounsfield units, water, fat, air, and the 2 from the bone. And then this has the advantage that the pseudo CT is in the exact same position as MR, so we don't have any sort of registration errors in registering the pseudo CT to the MR data sets, and we can contour directly on MR and plan on the pseudo CT. Just again to touch upon sort of optimizing MR imaging and the multidisciplinary team approach. So just an example how this might work. So we'll have our oncologist who might decide that they need MR images for to aid contouring a brain tumor case. The radiologist could advise on what type of sequences to use, so T2 weighted spin echo, a T2 weighted flare, and a T1 weighted post-contrast sequence. The radiotherapy physicist could state the sort of ideal geometric requirements that they need from the MR scan. So for example, 2 mil slices and less than 2 mil distortion over the entire field of view. And then the MR physicist could optimize these sequences to ensure all these conditions are met. Then the radiographer from radiotherapy background can ensure that the patient setup in MR is identical to that of CT. So this would also include making sure the immobilisation devices are correctly positioned and patient prep. And then the MR radiographer could, for example, ensure that the MR scan is carried out safely and correctly, and the patient and immobilisation devices are safe to scan and acquire the images, obviously. And this all needs a sort of feedback mechanism between the different staff groups to ensure that the MR images that we are acquiring are actually useful and appropriate for their intended radiotherapy planning. So to summarize that, we've seen that there's differences between MR for radiology versus radiotherapy treatment planning. There are different requirements for radiotherapy planning, such as different geometric limitations. The current MR sequences that you have on your scanner for planning may already be suitable, but just check and modify these if necessary. Developing and sort of incorporating the MR into radiotherapy workflow requires an MDT approach, and we're happy to receive any questions on MR for radiotherapy if you have any. And that's it. Happy to take any questions.
Okay, thank you very much, Michael and Lisa. That was really, really informative. We've been taking questions on the chat. We've got one from Laura Walsh, who says, are the protocols available on the website? So these will be the protocols you were discussing from the topical report, Michael.
Yeah, so that table that I showed is available in the IPEM MR radiotherapy guidelines, which is being published. So yeah, sure.
And we've got Jim Daniel with a question about 0.55 Tesla machines are available. These kind of things can help limit the concerns, burns, fat shifts, artifacts, question mark.
I mean, I don't have experience myself of these low field systems, but yes, you're right. There's lower risk of reaching your sort of RF SAR limits. Your fat water shift will be reduced because essentially chemical shift goes with your main magnetic field strength. But sort of con to that, I guess, is that if you're gonna be using sort of coil supports, table overlays, etc., this is gonna impact your SNR. You might have to do quite a bit of sequence optimization to get good SNR, and yeah, without actually having to go with that, I don't know how long your sequences will actually take to acquire. So there's pros and cons, I think. Be happy if you want to share your experience.
And then Lisa touched on that earlier, didn't she? In terms of the actual instances of burns, etc., are not necessarily as high as people report sometimes. Do we have any kind of feel for how often that kind of safety is?
I think they're massively underreported.
Okay.
I think that's the problem in radiology. I'm not convinced the relationship between skin touching the MR and the development of a burn would perhaps be necessarily something that the patient would put 2 and 2 together and realize that that's what's caused it. So most of the cases online are pretty extreme where the patient's been burnt severely. But the low level, I think it's just underreported. So we don't know. We haven't, touch wood, we haven't seen any on the MR Linac where we're seeing patients every day. And so we haven't seen any. But we are very careful. There is a question about getting the compression right. So we use it's a belt with a pneumatic bladder that you fill up. We use that for abdominal compression. So the tip is, what we've found is that if you get the part of the belt that goes around the patient as tight as you can while they're upright, then when they lie down, you tighten it a little bit more and then start to fill the bladder up. And then we mark the skin and create an acetate so that we then can place the acetate over when we re-put the belt on the following day. And that seems to work. That seems to work. It's a practical skill that staff get better with the more they do it. The more they use the belt, the better they get with it. But we use acetates and skin markings with pen.
There is another one there regarding sequences. Oh, can we take the question from Sam Telfer first regarding the use of propeller for certain sites as GE artist does not apply 3D distortion correction? I guess that's a question for Michael.
Yeah.
I don't necessarily have experience with the GE propeller-based sequence. I think as long as your sort of resultant images, so if you can only go with 2D distortion correction, as long as you're happy that you've characterized the sort of slice distortion with phantoms and you're happy with that, then that should be okay. But obviously you need to test those sequences.
I don't know if it's sort of a question to Sam really, but can you do 3D sequences with propeller? Because some radial sequences you can't do 3D.
So I think on the G propeller is someone can correct me if I'm wrong, but it's just a 2D acquisition. But there's probably stack of stars based 3D, essentially 3D versions of propeller, which might be available on G systems, which you can have a look at.
Good. I don't know whether you can see more questions than me,
Yeah,
Michael and Lisa. Have you got more?
We've got one about, oh, sorry, we'll go quiet because we're just reading them.
Yeah, sorry. Yeah, Cormac's question.
About the MP Rage.
Yeah, so I mean, that MP Rage was a Cartesian-based acquisition. We've not actually looked at spiral acquisitions, but we have, so Petra, but we've looked at sort of star vibe type sequences. You're looking at a Siemens system there, and those have passed our sort of radiotherapy QA tests. So we sometimes use star vibe for treatment planning, which is a stack of stars radio based sequence. Cool.
Good. I think trying to accommodate from a radiotherapy perspective, I would say that the survey was excellent at highlighting the differences in access to MRI and the problems that we've got in the UK and internationally. And then sorry, I'll come to that next question in a minute. And the topical report is excellent guidance. I would just ask the general question is kind of where do you see this going next in terms of, you know, I can use the topical report to try and influence relevant multidisciplinary teams to improve the access, but is there any more working parties on the boil to take things any further?
I mean, you're involved with stuff in terms of radiographers and like Society of Radiographers implementation.
Yeah, I think that there's a shift towards training and developing knowledge, and it's becoming more commonplace. I think the bottom line is it often boils down to finances and different trusts implementing using their MR systems, or radiotherapy departments buying their own magnets, which obviously costs money. And so it's the financial side of things that I think are probably holding it back. I think the clinical side is known about and we will push forwards, but I think it's held back by the financial constraints of paying for a service. In today's healthcare, we do have workforce shortages in the health service that we all know about, and I suspect Sarah touched on it last week about dualism in training. So having professionals that can cross the bridge between radiotherapy and radiology in terms of clinical scientists. And I think that may happen with radiographers as well. Radiographers used to be dual trained. There was a cohort of radiographers that were dual trained in the past when imaging first became part of radiotherapy, but image guided. And I think that there'll be a shift towards that. There are a few universities putting MR in radiotherapy courses on now for radiographers. That is becoming more commonplace.
Yeah, I think the other thing is with the report as well. I mean, I've definitely spoken to people from other centres that have started using the topical guidance report. So that's really good. I mean, hopefully, maybe in a few years, if we repeat the survey, we sort of see some increased consistency across the country. That would be a good result, I think.
Yeah, I think from my point of view that would definitely be useful, because I think the report's really massively useful to radiotherapy practice, and people like me will certainly use it as an argument for in more investment in MR and radiotherapy.
Yeah, the other thing is we also did an international survey which came the year or two later, where we looked at several countries across the globe and found that the sort of funding which goes into the UK MR for radiotherapy is sort of considerably less than other centres, countries.
Yeah.
I'll just answer that question about the breath hold. So breath hold systems, Oh, I'm not. We can't use things like RPM and that you might be familiar with in radiotherapy. There are some groups trying to develop a similar system to RPM, visual guided breath hold systems. The problem is having a TV screen in the scan room for them to see it. It needs to be put in at install rarely. And surface guidance, there is some commercially available surface guidance for breath hold out there. The Philips version is called Vital-I, and Vital-I works in a similar way to RPM, but I don't know of any clinical sites that are actually using it at the moment. I dare say if Philips have got Vital-I out, then the other vendors will have an equivalent, but I'm afraid I don't know what that equivalent's called. But it's not used in any clinical sites in the UK at the moment. For MR.
Good. Is there any more questions? Lisa or Michael, did you have any more on your screen that I couldn't see?
No, that's the bottom one.
I think that's it.
We are using surface guidance in the department here, on the treatment floor in photon,
Not MR.
but not in MR. Yeah.
Can I ask a really stupid question? That how do they see the surface past the coils?
You put something. You put a receiver on. Well, yeah, I don't know. I guess you set up. So I don't know if you noticed the two main setups, but the Philips setup is the coil bridge is basically an arch. That was the head and neck setup with the sandbags at the side. That's basically just it's just a frame that goes over it, so you could see you put the piece of kit on the chest or on the abdomen or whatever, so you would see it in those patients, and then you pop the coil over the top at the last minute.
Yeah, the camera for it is actually at the end of the ball, so it looks down through the ball.
Okay.
Of the scanner.
And could probably use points as a surrogate, I suppose. Of the whole service. Yeah. Good. So, in the absence of further questions, I think I would like to just thank Michael and Lisa again for a very informative talk. I certainly learned a lot today, and wrap up the end of the session unless there's any more housekeeping you two are aware of that I need to do.
I think the last slide is the next 2 weeks.
Aha. And then I guess we've got no formal communication as yet about next Monday, which is the bank holiday Monday, due to the Queen's funeral. So I guess we're going to await for IPEM notification of what's happening to that one.
Yes, sorry, Mark, if I can just step in. We are looking to reschedule next week's webinar. We don't have a confirmed date just yet, but we will be communicating that.
Brilliant. Thank you very much then.
Thank you.
Thank you.
Cheers. Bye-bye.
Bye.